Thank you. Good afternoon to everybody. First, I'd like to thank Julio and the organizing committee for having invited Viv to present at the meeting. Yesterday, I already thanked Anil for having covered in his presentation the topics I was asked to present today. I thought about changing the presentation. I thought it would be unpolite. So what I will try to do is looking at the same subjects, maybe on a different way. For me, it's also a bit hard to talk about supply and capacity enhancing, having at the table David Ripping. You know, it's like talking about football with Fabio or Giulio. My country only has the best player in the world, doesn't have the best team. So it's a bit hard, but I'll try to. So the subject will be is to reach the additional 19 million for going for universal treatment. Does the world have the capacity to produce all the ARVs? Can we deliver and store this figure? I'll explain how I got to this figure. This figure means 19 million people starting, all being tested, all being positive, all accepting to being treated, and starting all on day one and getting 12 packs on end of year one. That makes, it's very simple. I'm a physician, I'm not an economist or a man of figures, so this is multiplying 19 million by 12. And then the last thing is, we have produced the drugs, we have delivered them to the places where the people who are living with HIV live. How can we treat them? And on this, I would like to make a very clear statement. It's very important for me. Treatment as prevention for me obliges to respect of individual human rights. And I already mentioned what this is exactly what she mentioned is what it is for me. Nikos also spoke today, is the right for people to reject being tested and reject being treated. This is individual human rights. And also, we have to take in consideration that if we don't address stigma and discrimination, maybe everything that we said here today will never be achieved. I'm older than most of you in the room, so I was in the beginning of the epidemic already treating patients. The progresses were incredible. One thing I think has not changed is the stigma and discrimination that affects the people living with HIV, namely what we today call key populations, that in our time was not called like that, and mainly the LGBT community that still on the days of today is discriminated in all, let's call, chain of healthcare delivery. So, capacity to produce ARVs. Anil yesterday said that Milan is committed to supply and deliver what will be needed. If Dr. Yusuf Hamid, the owner of Cipla, will be here, he will say exactly the same thing. I've been traveling in China, and when I speak with China manufacturers, they also say they're scaling up capacity. But on Monday and Tuesday, there was a big meeting in Brussels called the EU-Africa Business Roundtable, where probably the most strongest recommendation was about enhancing and creating capacity to produce ARVs in Africa. This is a subject that's been discussed over time, and some of the critics have always said, well, it's impossible, it's too much expensive when you look at the capacity installed in India and in China, and what you can do in Africa, it's impossible. Have we ever looked what will be the impact in human development, in the skills of the people of building capacity in Africa? Maybe this will offset the extra cents that you will have to pay for drugs that are produced in India and China. And this is something that is very much at the agenda today. One of the major preoccupations of WHO Africa, and when I speak with my friend Luis Sambo, who is the head of WHO Afro, is the quality of drugs that are supplied today in Africa. I'm not only talking about counterfeiting, I'm talking about substandard drugs. It is very important that people live with HIV, namely the ones who live in Africa, we can ensure that they receive the best quality drugs. And that also we know that to deliver the capacity, and I don't want to enter in that because David can immediately say you don't talk about what you don't know, is we have to have the right procurement consolidation. WHO has to set the right guidelines. Countries have to accept the guidelines. Meg explained yesterday to us that notwithstanding that new guidelines were established with first line standard of care in Western world considered by WHO should be now first line, and countries still buy Nevirapine instead of buying what was indicated by WHO. That can be also one problem, but I think we can do it. Supply chain, it's very important, and something that I think there's lots of people around the table here that have worked on that. There is the need for regulatory harmonization in Africa. There's the FDA, there's the European Agency, there is with the scarce capacity that some African countries have at regulatory level, there is a huge benefit, not only on ARVs, but to have regulatory harmonization in Africa. This will be able to develop the people. Countries that, that have to accept pan-continental regulatory agency don't lose sovereignty. They can still take their own decisions, and they participate on the global decisions in terms of registration. One of the big questions is, can we deliver this 28 million to thousands of locations? It's very difficult. One of the programs we support in Lesotho, the people benefit and the clinic that we support, ARVs are in winter transported by horse, 24 hours. It's a journey it takes from the clinic where it's stored to the other clinic that supplies. So it's difficult, but it can be done. I'm pretty sure that my colleague at the table that runs Coca-Cola in Mozambique will explain us how any place you go, you find a bottle of Coca-Cola. I'm not making advertising. I hope that it is in my declaration of interest. You saw I'm not an employee of Coca-Cola, but that is the reality. We see a bottle of Coca in any place we go, but we also see mobile phones. So we probably could use better, the infrastructure that is implemented for other goods to distribute ARVs and other medical goods. Then, if we are successful in producing the drugs, if we can make them arrive where people are, do we have the capacity and enough human resources to treat people? Richard Hayes from the London School of Hygiene and Tropical Medicine published in 2011 probably one of the most comprehensive papers on how to deliver treatment in the context of treatment as prevention, and he mentioned 4 different possibilities. Home-based care, there's a very good program that's described in Uganda, where of course you have to have healthcare workers or community workers that can deliver this home-based care. It can be. Are we using at the best and maximum capacity the current facility-based provision? Are we using the clinics that provide sexual reproductive health services, that provide vaccination services? That's the thing. Community treatment centers. I saw in the presentation of Médecins Sans Frontières yesterday the results that community provision in Mozambique, in the province of Beira, where they showed results of 96% retention to care. I'm pretty sure that some of the physicians working in developed countries here will be very glad to have 96% of retention on care. So it's probably one case, but we can build on these cases if we really have the will, if we want to do it. And of course, workplace provision. The most well-known case was in South Africa, when the mining industry, at the times where President Mbeki considered that HIV was provoked by something strange and treated with garlic. Some of these companies like Anglo, they start providing therapy to their workers. But if you consider the largest concentration of workers in Africa, still today, days of today, are in mines, plantations, in ports, we could also oversee ways of delivering the treatment to people. Then we can say, okay, we can produce, we can put them where the drugs where people need it. We have enough resources to treat them. Can we pay for them? Well, lots of people have already addressed this subject here today and yesterday. I learned a lot with our moderator. Yesterday I learned also something very interesting. When the subject is very complicated, you present slides that nobody can read, and you get it to the extreme. You yourself can't read, so nobody can criticize you. So that was what I learned a lot with you yesterday. So I'm not going to enter on that. Today I've seen great presentations, and David already spoke. But I just give you this sense. TARP, do you know what TARP was called? The Trouble Asset Recovery Program. That was injecting money in the banks in 2008 in the US. Some people said it cost 700 billion. Some others say it was more than 1 trillion. In Europe, and that went out of my pocket because European governments immediately take the money out of taxpayers, in 2008, $5.3 billion were injected in the banks, European banks, to save them from collapse. The country where I live now, the UK, injected himself, only the government of UK, $781 billion on the banks. So, it's no money. If you make the, with the figures that David showed, we can pay for lots and lots of years of universal treatment if we just do a small portion of this kind of investment. At this stage you say, well, this guy is, for him everything is nice, beautiful, very easy to do. Can we really do it? And I'd like to share with you this table that is, I'll say to my friends in the United States, probably one of the best slides they ever produced, because it can show us in a very simple slide, when people want to change the situation, they can change. For those of us who are here for many years, we were all frustrated in the beginning of 2000 because things were not advancing. And all of a sudden, there were 2 events. One was creation by someone that we will never expect created by President Bush of PEPFAR, and there was the creation of Global Fund. So all of a sudden, there was money. Together with that, pharmaceutical companies like mine and my shareholders were forced by community to provide licenses. Generic companies start producing ARVs in India. The prices went down. So what we saw, we had 1 million people in therapy in 2005. We have 9.7 in 2012. So why can't we also change the situation? Why can't we say that if we want, I'm not going to use the cliche, yes we can, too many people use it today. But really, if there is the will to do it, why shouldn't we do it? And because Anna used a little more time, I will now try to save some time, and I will leave with the same thought from the same author that she chose. I think that if you want to do it, this is the right time to do it. Thank you very much for your attention.